Okay, let's go ahead and start our next session. Welcome back to the track for the Introduction to Mental Health and IDD. In this next session, senior leaders from the Texas Health and Human Services Commission are going to provide an overview of their respective divisions and the services they offer in connection with mental health, IDD, and forensic services. We have with us Deputy Associate Commissioner Ann McGonigle with Community Services, Associate Commissioner Dr. Jennie Simpson with Health and Specialty Care Systems, and Associate Director Reilly Webb with Behavioral Health Services. Welcome to our panel.
I think it's right there.
Gotcha. All right, good afternoon, everyone. Welcome to HHSC Basics. My name is Reilly Webb. I think they sent me because I'm probably the most basic person at Behavioral Health Services, but I think that's a Gen Z slang now. I don't quite know what it means yet, but I have the privilege of being the Associate Commissioner for Mental Health Programs. And really just the purpose of my slides here today is to give a brief overview of Behavioral Health Services Division within HHSC, and hopefully answer any questions that y'all have, then I'll turn it over to my colleagues. In terms of the agenda, I just want to talk briefly about our mission and vision. Maybe the most valuable thing that you'll take away from this presentation is the org chart that we'll be sharing, just in terms of who you need to contact. Talk about our funding sources, touch on the model, our Texas Resiliency and Recovery Model, and maybe highlight some of the few programs that we have within Behavioral Health Services if there's time. So very simply, our vision at BHS, or Behavioral Health Services, is to ensure that Texans have access to the right behavioral health services at the right time, the right place. We want to do that by establishing behavioral health systems of care that achieve meaningful, clinical, and cost-effective outcomes for all Texans. I mentioned I would share our organizational chart within the agency. Our Executive Commissioner is Cecily Young. She has the Chief Program Services Officer, Michelle Loletto, in which we are all under that CPSO umbrella, which includes access and eligibility services, health and specialty care system, behavioral health services, and community services. So Trina Ida is our Deputy Executive Commissioner within BHS, and then those blue boxes there are her direct reports. I am over the mental health programs, and in my area I have behavioral health Medicaid programs, our medical director's office, our adult crisis and forensics area, our children's mental health area, and our disaster behavioral health area. In terms of how we do our business at BHS, our funding sources, we really have 4 buckets of funding. That's the appropriations that we get from the Texas legislature through general revenue. We have our community mental health block grant, our substance use block grant, and other dedicated and discretionary federal funds. So how does somebody access community-based mental health services in Texas? We really want to take that no wrong door approach. Whether that's someone contacting their local mental health authorities, local crisis hotline, or 988, if they're having a scheduled intake, if they're walking in to get an intake assessment. 33 of our 39 local mental health authorities offer walk-in appointments for intake assessments that are completed the same day. We want to divert people from emergency rooms, psychiatric hospitals, jails, and we have 11 OSARs, which are outreach, screening, and assessment and referrals, which are really also housed within the local mental health authorities that are the starting point for someone who needs substance use services. The local mental health authority system, really the safety net system for providing community-based mental health and behavioral health services in Texas. They're there to serve as the point of entry for mental health services for Texans who have a mental illness. People can be publicly funded, privately funded, underfunded, unfunded, and they're really there to provide those services to individuals that reside within the catchment area. If you need assistance finding out who your local mental health authority is, you can simply Google Find My LMHA, and The first link that will come up will let you put in your address or your county and point you towards your correct local mental health or behavioral health authority. 38 of our 39 local mental health authorities are certified community behavioral health clinics, and this is really the goal there is to improve access and have less disruptions for people that are needing both mental health and substance use services. We have 42 total Texas CCBHCs, so we have 4 that are not LMHAs. And that's really, again, a model that we're proud of to integrate services within those areas. In Texas, the framework in how we deliver those services is the Texas Resiliency and Recovery Model. The predecessor was the Resiliency and Disease Management Model, RDM, that came into use, I think, in the 79th session, so that would have been 04, 05, and I think around September of 2012 that name was, and that framework was updated into TRR. But really that model establishes the eligibility for someone that can receive mental health services and recommends them into a level of care. An important stat there is that between 98 and 99% of people that are enrolled into services at the local mental health authority avoid needing to go to a state hospital stay afterwards. So the eligibility criteria, very simply for children ages 3 through 17, is a child with a serious emotional disturbance. That's anyone with a significant functional impairment to their family, their school, their community. And for adults, it's those with serious mental illness who require crisis resolution or ongoing support and treatment. That assessment's done through a standard process called the ANZA for an adult, which is the Adult Needs and Strengths Assessment, or for children, it's the Child and Adolescent Needs and Strengths, the CANS. So for levels of care, this is what I was referencing in terms of an intensity-based system for someone that is getting assessed and then being recommended or authorized into a level of care. It goes basically in order of intensity. This is the level of care tree, I suppose, for children, starting with level of care 1, medication management. We're talking about routine care, brief interventions. Level of care 2 is your sort of regular therapy or stabilization of symptoms, having improved functioning with your family. Level of care 3 would be to prevent hospitalization or strengthen family supports. This is more frequent therapy, more skills training, incorporating certified family partners. Level of care 4 is really when we're trying to avoid residential treatment or hospitalization. It's that more intensive case management. Very similarly for adults, the same sort of level of care tree here. I won't cover that, but very similar hierarchy there. For fiscal year 24, just to give you all an idea of the volume of people that our local mental health authorities are seeing, it was over 100,000 children, over 300,000 adults, for a total of 426,000 served or enrolled into a level of care during FY24. I just wanted to, like I said, I wanted to highlight some of the programs that I thought y'all might be interested in. This is a very small snapshot or sample of some of the programs that we operate throughout the state. 988 is the easy to remember 3-digit number that anybody can text, call, or chat to get access to emotional support services. We answered more than 18,000 calls throughout our local mental health authorities that are 988 Lifeline sites per month at an answer rate of about 77%. We're currently engaging in a campaign to raise awareness about that program that's launched as of last month and will run through mid-November if anybody's seeing any advertising or marketing for that program. Youth Crisis Outreach Teams was a program that was piloted 2 sessions ago. We received $7 million in each fiscal year, the 2 bienniums ago, to establish those YCOTs. Every local mental health authority in Texas operates mobile crisis outreach teams. This is a little bit different in terms of that it was geared towards youth and families, and wanted to incorporate making sure that there was those follow-up services for 30 to 90 days after making contact and crisis assessment for those families. So for 26-27, received $27 million for each fiscal year, and the legislature's directive was to establish at least 8 new programs across the state, so we'll have a total of 16 operating by the end of this fiscal year. Our state hospital step-down program, we currently have 3 LMHAs with a total of 5 step-down homes. Really, this program is designed to accept people who are ready for discharge from the state hospital system, who have been there for more than 365 consecutive days. And we've accepted in FY25, 24 people discharged from state hospital to one of those step-down homes. And we graduated 27 of those individuals back to independent living in the community, and that's really the goal of that program. Our average daily cost in FY26 so far has been $492 to operate a day to operate that. I'm sorry, per bed to operate that program, and there's some significant cost savings there compared to a private psychiatric hospital or a state hospital. Our jail-based competency restoration program, we have expanded that from fiscal year 22 to a total from 6 programs to we currently operate 19, so triple that over the past 3 or 4 fiscal years. Our goal there is to restore defendants' competency to stand trial rather than transfer them to the state hospital. Our jail diversion centers are sort of a new initiative, a new program that we've been experiencing some popularity with from our local mental health authorities, but those are designed to help people with serious mental illness who are experiencing a mental health crisis get access to services without having to go to jail. And so the benefits of that have been minimizing wall time for law enforcement officers who are avoiding having to spend time-related incidents with people experiencing a behavioral health crisis, and make sure those people are getting access to outpatient recovery services and supports. Currently, we have 10 jail diversion centers that are operating. We've got a couple more that are coming up in FY26. Lastly, we have mental health deputy and co-responder programs. I'm sure you all are familiar with those, but in terms of funding programs that fund law enforcement officers that are trained in crisis intervention to respond to behavioral health crises, or having a co-responder model where a mental health professional accompanies a law enforcement professional on scene. I think I'm just about at time here, so I'm going to flip through. Here's our map for mental health deputy and co-responder programs. Lastly, I'll just mention that the framework in terms of how we fund a lot of these programs hinges or is dependent upon receiving the resources and appropriations to do so. And we do that through our grant opportunities that we fund at BHS. And so I've listed some of those here with some of our statistics and outcomes. But I encourage y'all to look at our website and make sure that you're periodically checking for grant opportunities as they come available. With that, I will turn it over to Ann McGonigle from Community Services.
All right, thanks, Reilly. Let's bring this down. Hey, sorry. All right, good afternoon, everyone. Really pleased to be here. So let's see, let me get to the right slide. I will not have an org chart to show you, but when Reilly was discussing where behavioral health services falls under the organization at the Health and Human Services Commission, he mentioned community services that falls under the Chief Program and Services Office, just like behavioral health services. And so that's where we fall. That's my area. I'm part of the Community Services Division, specifically in the IDD services section. So primarily, I'm going to talk to you guys about the local IDD authorities. Do we have any LIDA staff here? I'm just curious. Okay, wonderful. A few folks. Might get some repeat information, but information you already know, but I'm glad we've got some folks who maybe aren't as familiar. I'll also talk a little bit about the Texas No Wrong Door System and the HHSC Office of Guardianship. Okay, so the Texas No Wrong Door System coordinates access to long-term services and supports offered by the state and local organizations. The idea is to empower individuals and caregivers to make informed decisions about their long-term care using a person-centered approach. So it consists of multiple front doors through which people can access services. Those front doors, you'll be familiar with a lot of them. They include 211, the Your Texas Benefits site, area agencies on aging, aging and disability resource centers, centers for independent living, both the local IDD authorities and the local mental health and behavioral health authorities, the Community Partners Program, and community care services. All right. So ongoing efforts related to No Wrong Door include enhancing awareness and understanding of the No Wrong Door system through evaluating and improving its governance and administration, the consistency of person-centered counseling, and public outreach and coordination across the system. HHSC received a 2-year grant from the Administration for Community Living to develop an information management system for Texas Aging and Disability Resource Centers, to develop a gap analysis of the IT systems used in the No Wrong Door system, to develop options for an integrated system and a closed-loop referral pilot between a local ADRC and 211 Information Center. All right, so moving on to kind of the meat of the information I want to share today. Intellectual and developmental disability services in Texas are delivered through a variety of means. Most of the information I'm going to share today is about the local IDD authorities, or LIDAs, which help people access IDD services on behalf of the state. In addition to the LIDAs, intermediate care facilities serve people in private, community-based group homes and in publicly run state-supported living centers. Community First Choice is a Medicaid entitlement program that provides personal assistance and habilitation services to children and adults. And the Medicaid waiver programs serve people in the community to help them avoid institutionalization. We call these 4 that are up on the slide the IDD waivers, though there are other waivers that are designed for people with high medical needs, whether or not they have an intellectual or developmental disability. So the LIDA's role as part of the No Wrong Door system is to serve as the single point of access to publicly funded IDD services and supports for the residents who live in the LIDA service area. They serve people with intellectual and developmental disabilities who live at home in the community, who live in nursing facilities, state-supported living centers, and community-based intermediate care facilities. LIDAs collectively serve more than 70,000 people each year. So as part of their roles and responsibilities, LIDAs conduct intake activities, such as sharing information about IDD services and community supports, completing diagnostic testing and evaluation for eligibility for publicly funded programs. In addition to that, they're also responsible for placing people on the interest list for the HCS, Home and Community-Based Services, and Texas Home Living waiver programs, and making contact with them every 2 years that they're on the interest list. And they perform enrollment activities for HCS, Texas Home Living, Community First Choice, non-waiver, and intermediate care facilities, including state-supported living centers. Once an individual is enrolled in HCS or Texas Home Living or a few different programs, the LIDAs provide service coordination to monitor services for as long as the person is in the program. Service coordination is really kind of the bread and butter of the LIDA role. There's a lot of things, functions that the LIDAs carry out, but those intake and access activities and then service coordination are kind of 2 of the largest and most critical. So service coordinators conduct in-person visits with individuals to monitor the delivery of outcome-focused services and supports that address their needs and desires. They also follow up with the person's network of both paid and unpaid supports and conduct planning meetings to revise or renew their plan of services. LIDAs also receive some state general revenue funding to support people in the community who have intellectual disabilities or related conditions, such as autism spectrum disorder, who are waiting for services in a waiver program. Maybe they're sitting on one of those interest lists, or maybe they're not eligible for those waiver programs or for other Medicaid programs. They can be served by the LIDAs using general revenue. The LIDAs are required by contract to provide service coordination and respite using those funds, and they can choose to use their allocated funds to provide additional services like behavioral support and employment assistance. LIDAs also conduct what are called PASRR evaluations for people who are seeking admission to or diversion from a nursing facility if they're suspected of having an intellectual disability, a developmental disability, or a serious mental illness. All right, and then real quick, permanency planning is a process that helps a child or young adult and their family address how they're going to remain connected with one another while they might be in an institutional setting. Planning includes specific actions to be taken by all parties to facilitate communication, visitation, and joint planning with the goal of a successful return to the family or to another supportive family-like environment. And then I'm gonna go over some of these other programs on the slide, starting now. All right. So crisis services. At times, people with IDD, as many in this room, I'm sure, if not all are aware, can exhibit significant needs requiring additional support beyond the array of services that are typically provided in the community programs that serve people with IDD. Every LIDA has at least one crisis intervention specialist who collaborates with other LIDA staff to identify people with IDD who are at risk of requiring crisis services. They collaborate with service planning teams to identify prevention strategies to avoid potential crisis events and to promote the person's use of their coping skills. They also offer training and support to the staff in the person support system to give them the best chance of being successful in the community. The crisis intervention specialist interactions with mobile crisis outreach teams help MCOT staff develop a more effective response to people with IDD who are in crisis. They also make referrals to crisis respite services to address a person's acute needs for stabilization and support. And additionally, the crisis intervention specialists help service planning teams address concerns such as involvement with law enforcement or emergency room visits. And when someone with IDD requires even more intensive supports to stay in the community and avoid incarceration or hospitalization, crisis respite can be appropriate. The purpose of crisis respite is for the person to stabilize within a relatively short period of time. In some cases, crisis respite is also used to help an individual transition to the community by stepping down from a hospital stay or from a psychiatric facility. And you can see we have both in-home crisis respite options as well as out-of-home. Out-of-home crisis respite can be offered in a licensed home or through a mental health crisis respite facility. All right. LIDAs facilitate both diversions and transitions for people who want to avoid institutionalization or relocate from an institutional setting into the community. People transitioning or diverting from state-supported living centers, nursing facilities, or medium or large intermediate care facilities, and enrolling into one of those IDD waiver programs are eligible to receive what we call Enhanced Community Coordination, which is a Money Follows the Person federal grant project. Enhanced community coordinators conduct pre-move site visits before a transition occurs. They complete post-move monitoring for 90 days after the move, involving visiting the person kind of at least 3 times within that 90-day period to make sure that essential supports are in place and the transition is going well. And then they offer enhanced support for a year after the person moves to make sure that any risk factors for reinstitutionalization are addressed timely and effectively. All right, and through another Money Follows the Person grant, we have 8 LIDAs across the state that are contracted to operate a transition support team in their designated areas. TSTs conduct educational activities and provide technical assistance and case review to other local authorities as well as to private providers with the goal of helping them address the complex medical, behavioral, and psychiatric needs of people with IDD that are living in the community. TSTs offer case consultation to help LIDAs and providers consider ways that a person with IDD who has those significant needs can be served in a non-institutional setting. And the educational activities and technical assistance that they provide are designed to support frontline staff to deliver more effective services. All right, we've also got our outpatient biopsychosocial interventions. These are outpatient mental health services for people with IDD that were initially funded by the 86th legislature and were piloted at 5 LIDAs to meet the needs of people with IDD and co-occurring mental health or behavioral needs. An exceptional item was recently funded by the 89th legislature to expand the success of OBI to 8 additional LIDA sites, so we're excited to be rolling that out soon to 8 additional LIDAs for 13 total sites across the state. OBI provides an evidence-based biopsychosocial approach to care, including person-centered and trauma-informed treatment plan. It includes a holistic case management approach focused on increasing access and creating a team of medical, psychiatric, mental health, and paraprofessionals to address the person's unique needs. It provides skills training and mental wellness to support both the person and their support system. And it also provides education and training on co-occurring IDD and mental health conditions to practitioners in the mental health, substance use, and related fields. All right, and finally, I just want to touch briefly on the HHSC Office of Guardianship. Guardianship is a legal process established by a court with guardianship jurisdiction and does require an attorney. HHSC's Office of Guardianship provides direct delivery of services and also contracts out for guardianship services. It's important to note that they can only accept referrals in specific circumstances, and therefore they're really just a small part of the guardianship system in Texas. But if you are interested in learning more about guardianship or about HHSC's Office of Guardianship, you can find more information on HHSC's website, which is hhs.texas.gov. And then look for the Texas Guide to Adult Guardianship. And that's all I have for you this morning. Thank you so much.
Okay, good afternoon, everyone. I am Jennie Simpson. I'm the Associate Commissioner and the State Forensic Director, and I am in the Health and Specialty Care System. So I'm going to kind of close the thread here. So my colleagues are on the community side of the house within the Chief Program Services Officer Division. My division, the Health and Specialty Care System, oversees our 13 state-supported living centers and then our 11 state hospitals. We also have 1 youth residential treatment facility. So the way to kind of think the differentiation again is they're on the community side of the house. We are the more institutional and facility side, but we work really closely together, and we are serving similar populations, the same populations who may go community into one of our state-supported living centers, into our state hospital, back out into the community. So this presentation really is to kind of draw the line for a really large agency, how the people that you work with every day, we serve, how we're all related together. So I'm going to try to do this in 7 minutes so that we also have time for y'all to ask questions, because I think that's really important for what you may not understand or still have questions about. We'll have time for that. So the organization of the Health and Specialty Care System, Scott Shacklin, who is a commissioner for the JSMH, is our Deputy Executive Commissioner. And we have 5 associate commissioners. My colleague, Erin Knight, is the Interim Associate Commissioner over the state hospitals. And then Laura Casabon-Brawley is the Associate Commissioner over the state-supported living centers. And I am the Associate Commissioner over the Office of Forensic Services and Coordination. So the 3 of us are very connected. They are over the facilities, and I span forensic services for the system. So our Texas state hospitals, we have, as you'll see here in the map, we have hospitals across the state of Texas. We have 1 youth residential center, 1 primary care outpatient. We have over 250 contract beds we provide, and then of course our 11 state hospital facilities. So the services within the state hospital. So of course we provide psychiatric services to adults, children and adolescents, as well as geriatric populations. We also provide competency restoration services, as most of y'all are very familiar with, for both adolescents and adults. And then we also provide psychiatric services to people found not guilty by reason of insanity. So waitlist placement. I know we often get a lot of questions about the forensic waitlist. I'm sure all of you are familiar with that. The forensic waitlist is first come, first serve for those who are on non-maximum security unit charges. So that's our non-MSU list. That's first come, first serve. It is done by catchment areas for the state hospitals. Now, for our maximum security, individuals on maximum security charges, they go to the first available bed in one of 4 state hospitals that serve MSU populations. So that's Kerrville, that's Rusk, that's Vernon, and Wichita Falls. So just to kind of make sense, whenever we say the forensic wait list, there's 2 really. We're looking at those that are non-MSU that go into a catchment area of their state hospital, and then the MSU, which is one of 4 facilities. So treatment goals. So for our not guilty by reason of insanity, so what we're really, when we're looking at treatment for this population, the goal is long-term recovery and community integration. So the treatment is going to be tailored to that. Now, on the other side of a forensic commitment, we have the incompetent to stand trial. The treatment goal is medication management, psychiatric stabilization, and legal education. So really, when we think about those forensic populations, there's 2 real treatment and commitment goals for those. So some of the key considerations that I'd love for you to walk away with when you think about the state hospitals. First, they're treatment facilities, first and foremost, and they're not long-term solutions for people who are found incompetent to stand trial. Again, like I said, our goal for those individuals is to stabilize psychiatrically, provide medication, and return someone to stand trial. The goal for competency restoration is to restore someone to competency. And that is very clearly what the service we are providing to those individuals, of course, with all the other treatment services around it. And we see that research does show that people who are going to restore to competency, they generally restore within 6 months. So when people, and this is to the last point here, when people who are in the hospital who don't have, they're not really working towards achievable goals, whether that be community reintegration or competency, staying long-term really reduces access for other people who need admission into the state hospital. And this is kind of that front door and back door that we talk about in forensics. So front door, we have people who need to be admitted, but we also have people who need to be discharged. And that's for those who are found incompetent to stand trial and those found not guilty by reason of insanity. Okay, I'm going to transition to our state-supported living centers. So we have 13 state-supported living center. Each state-supported living center is an immediate care facility for intellectual and developmental disabilities. And we served over 2,000 people in fiscal year 24, sorry about that. So there's 4 different types of forensic admissions to our state-supported living centers. Those are for the initial commitment for competency restoration. There's the extended for competency restoration, and then we have for adolescents found unfit to proceed, we have the initial and then an extended commitment. So all 4 of those we have those individuals committed on those in SSLCs. So our services, they're a little bit different than our state hospitals. Of course, there's psychiatric treatment, there's medical treatment, but our state-supported living centers are residential facilities. So they are providing, and they're also tailored towards individuals with IDD. So the services are going to look a bit different. And of course, for forensic services, competency restoration, we do high-risk determinations to determine where someone's risk level. We also do individual and group counseling, community integration, working especially with the court and with the LIDA over in community services. And some of the key considerations, again, for forensic commitments. First of all, our state-supported living centers, they are, and this is something often I think people may not fully understand, is that they are very different than our state hospitals in that they operate as an intermediate care facility for intellectual and developmental disabilities. So there are CMS guidelines for that, and So some of the more restrictive practices that are allowed in state hospitals are not allowed in our state supported living centers. So again, it's just a bit different. And I think there's a lot of confusion that if you are, putting someone on a forensic commitment to a state supported living center, it's going to be the same type of restrictions and supervision, and that's not the case. So the other point here, and this is to the point I made with the state hospitals, is that the goal for people in SSLCs on forensic commitments is to return to the community as well. And so again, it's also that admissions and discharge. And finally, I think I'm almost at my goal here. The Office of Forensic Services and Coordination, which I oversee, operationalizes the statutory responsibilities for the state forensic director. And so we do several different pieces here. So we provide clinical services and supports that kind of larger system-wide perspective on that. We do strategic planning for the health and specialty care system. We do research. We really coordinate across the agency too around forensic services and individuals under forensic commitments, training and technical assistance, and then we do have statewide forensic programs. So that's what I'm going to leave you with. Many of y'all may be familiar with the Jail in Reach Learning Collaborative. Some of my colleagues presented on that last year. We are actually turning that into a statewide program available to any county across the state. So we will be launching that end of the year. There will be an online portal where you can request access. You can ask for a brief screen for clinical competence. We will provide training and technical assistance, but this will be for any county. Prior, it was just for cohorts in the Learning Collaborative, but we're opening it up. And of course, we are available for any kind of technical assistance request you have, any information you need. You have my email, you have the forensics email, so please use it if you have questions. We are more than happy. If we can't answer it, we'll get you to the right place, and it may be to my two colleagues over here. So with that, I want to open it up to the floor, because I do think it's important for y'all to be able to ask questions of us for any part you may not understand about HHSC. Let me ask, first of all, how many of you learned something about HHSC that you did not know? Okay. How many of you thought that state hospitals fell under behavioral health services? Yeah. Or vice versa. Yeah. Or didn't know. Excellent.
My name is Chris Sanders. Is a SIM mapping required for a county to qualify for your jail in reach?
No, a SIM mapping is not required for jail in reach.
Hi. Well, that was very informative. I wish we had more time. So, as you know, people with IDD are coming into our jails way too often. So I had the opportunity to work with the IDD population for many, many years, and how I interpreted behavior and developing behavior interventions, and all of a sudden, that's not happening in the community. So group homes are calling the police. Mm-hmm. There's a lack of behavioral supports in the community, and we're seeing these people in our jails. So I could go on and on. One particular situation that really is concerning is people with IDD often have inappropriate sexual behaviors. So, in my olden days or earlier days, we would do skills training and programming for that. And so what I see often now is that actually there's incidents that happen, and then all of a sudden there's a charge. And that's a serious charge, because often the victim is another person with a disability in the group home. So that becomes a sexual assault charge against a person with a disability, a felony, which then leaves us very few options. Thoughts? And I know we have struggled with the rates, with, the HCS rates, the lack of programs. I'm glad that there's, we're seeing more programs, but, that continuum of care for people with IDD has really gotten watered down over the years, in my opinion.
Yeah.
Not that I have an opinion, but I do.
Yeah, thank you so much for your thoughts and input. I agree. I mean, I think we are seeing, from anecdotally, if nothing else, hearing that the system is under a lot of strain. Not that I don't know that there's ever been a time when it wasn't under strain, but certainly, things like expectations of providers and rates are making it potentially more challenging to support people to help them stay in the communities. That is where, at least within our programs, where we're happy to receive the additional funding for those outpatient biopsychosocial interventions expansions, because we have seen success with that. We've looked at the data and we've seen lower rates of hospitalizations, emergency room visits, police involvement. So we're hoping that is a model that we can expand a little further across the state, maybe eventually all the way across the state. And those other options, like the crisis intervention specialists, I think it was the 2015 legislative session where they did kind of infuse some crisis funding to the local IDD authorities that are used to try to support folks. But we know that it's not sufficient funding. Not everyone is able to serve everyone who might benefit from crisis respite. So it's certainly something we continue to look at opportunities to improve those programs with the funding that we receive. And I'm always open to input, suggestions from what you're seeing. If you want to send me an email or come up to me afterward, I'm always happy to hear ideas if folks have it for how we can better serve the population.
Thank you.
Thanks.
Hi, good afternoon. I have a question from online. So someone asked, Texas has a database for those with guardianship/conservatorship for those involved with LIDAs. Is this information in that database? I could see the cross-system need, so those who become justice involved or are taken to crisis intervention.
Yeah, so I am not an expert in guardianship services, and like I said, there are resources on the HHS website, but I think that that certainly guardianship is complicated. It is something that crosses from of course impacts individuals and families, but also crosses over into the court system, which is not a lot of folks are not familiar with. They don't really parents may not realize that if they want to maintain guardianship, they have to start planning for that years before their child turns 18. So I would, I think there is certainly a need, and we can work, improve our coordination, resources that are available. I know that it is can be very complicated, can be very challenging to navigate the guardianship system in Texas. And again, just always happy to receive input. Again, I'm not over the area that the HHSC Office of Guardianship, but certainly see the need for additional resources there.
Great, thank you.
Mm-hmm.
Hello. Thank you for all the information. I feel like I'm sort of familiar with HHSC, but I definitely learned things I didn't know, so thank you for that. This is a question, I guess, that I'm kind of just seeking your input, any thoughts you have, anything you can share. I'd be interested to know. But so this is in reference to Executive Order 14332, which was titled Improving Oversight of Federal Grant Making. It kind of included some directives about kind of increased oversight by political appointees, power to terminate grants, explicit funding prohibitions, things along those lines with regard especially to mental health kinds of programs, IDD, substance use, things like that, as of course you all know very well. I'm just curious if you have any thoughts on, is that going to affect any of the programs that you are in charge of? Is that going to, do you foresee that kind of impacting communities that you're serving, and in what ways?
I'll take that one. I know that that executive order that you're mentioning does impact and did touch on a lot of the grant programs that the agency has across CPSO. BHS has several of those, including the block grant. I know that that guidance, we're expecting additional guidance from the federal awarding agencies. And our agency is looking at that executive order to analyze that and try to be able to disseminate information where it's possible. But our expectation is that contractors adhere to federal law and regulations wherever possible. But I know that's a nuanced topic, so I'm not sure I'd be able to give you a succinct answer in this forum. Thank you, though.